Ladies and gentlemen, welcome to the Office Hours Quarterly Hospital Readmissions Report conference call. Your host for today, Ross Gatsky. You may now begin.
Thank you. Good afternoon, everyone. My name is Ross Gatsky, and I'd like to welcome you to today's Office Hours for the Quarterly Hospital Readmission Report, which is presented by the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of three organizations: MPRO in Michigan, Stratus Health in Minnesota, and Medifar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. We wanted to offer you this call as an opportunity for you to learn more from your peers on how they are using the readmissions report and answer any questions that you may have. Also, the feedback that we received today will be helpful for us to make any appropriate changes to the report or to make them add more value. There is an evaluation survey at the end of the call that opens up in a new tab on your desktop after the call ends, and we would greatly appreciate that you complete that short survey. Also, this session is being recorded and will be available for viewing on the LSQIN YouTube page in about 2 weeks. The creation of the hospital report was really a collective effort of multiple team members from the Lake Superior Clean team, which included contributions from all 3 states. Project specialists from the Coalition of Care and Hospital Quality Reporting Tasks were involved, as well as data analysts, obviously, as their hard work and expertise. Without that, these reports would not be possible. And some of these folks that you see on the screen are present on the call, so you may be hearing from them today. Really, the purpose of this call is meant to be a sharing call, not necessarily a didactic or learning presentation where we present a bunch of slides and I do all the talking. Therefore, it would be very much appreciated if we receive active engagement from our attendees today, and please be looking to share experiences or questions related to the content. Since this readmission report relates very much to coordination of care, we have a link on this slide to our coordination of care task on the LSQIN site if you are interested. Also, some of you may not be as familiar with the readmission report or the content within the report. Therefore, the LSQIN held an introduction webinar to the readmission report held back in April, and there is also a link to that recording of our the LSQIN YouTube page. So if you are looking for a more detailed explanation of the content within the readmission report, we suggest that you check that recording out. Finally, we also want to mention that there is a possibility that you have not yet received your readmission report. The LSQIN has sent out a readmission report for every PPS and critical access hospital in the 3-state region. But for many hospitals, the report was only sent to one person who was designated as a central contact. So if you have not received the report but want to know who your hospital central contact person is, please feel free to connect with your state's LSQIN contact after the call, and we'll provide that contact information at the end of the slide. We hope as a result of today's call that you learn more about the readmissions reports through a question and answer session with the LSQIN report creators. You also will have an opportunity to hear how some of your peers from other hospitals are using the reports at their facilities to support quality improvement efforts. And finally, that you learn about important updates related to readmissions. We at the LSQIN feel that these readmission reports can serve many different purposes for you and your hospital staff. The data and information in these reports can assist you in areas such as internal tracking of specific patient segments, benchmarking prior hospital performance for setting future goals, identifying demographic or diagnosis specific areas that may have high readmission rates that are needed for improvement, and also using the report's patient transition and post-acute information to identify opportunities for improvement with post-acute organizations that service your patients after hospital discharge. So with that, we have a couple hospital contacts that we have queued up that we'd like to share with the group of how they are currently using the reports and what kind of value that they find within the reports. So Linda, if you are available and would like to call in and share how you're using the reports, we will begin with you.
Can the operator provide instructions as to how the participants could get on the line?
At this time, please press the number 1 key on your telephone keypad. If you have a question at this time, please press the number 1 key on your telephone keypad.
Hello, Ross?
Hello, Linda. Thank you for calling in.
No, thank you. I'm a care coordinator here at Monroe Clinic, and I find these reports very valuable. What I'm able to do, I'm tracking the patients because I'm calling them daily, and I'm also tracking when I have a readmission. But what I'm able to do is take this information that you've given me to the hospitalist meetings, and because I don't have time to do the graphs that show how we're doing over time, these graphs are also invaluable. They also help to verify that we're looking at the correct populations that we need to show improvement on. They're also very good at helping us being able to benchmark.
Great. So using them for a number of different things, and obviously you're tracking patients' readmission and other information internally, but you can also find value in these reports that they provide some supplemental information, and that's really one of the goals that we'd like to have with these reports is we like to add an extra layer of support to already existing data collection processes, and we're happy that you find these reports valuable. So thank you, Linda, for sharing, and we really appreciate it. And we had one other hospital contact queued up, so if Christian Schroeder from Park Nicollet Hospital could call in is it *1?
That's just the number 1 key.
Okay.
Ms. Schroeder, your line's now live.
Hello, Kristen.
Hi. So at Particulate, we use this report overall just to make informed decisions on readmissions interventions. At Particulate, we also participate in the next generation ACO, which is an ACO for fee-for-service Medicare patients. So this information is really helpful to us in addition to the information that we get from Medicare. And one of the initiatives that we've recently used it for is to understand which populations would be best to provide the post-DC home visits waiver to. This is a waiver that Medicare offers next-gen ACO that participate. They allow us to go and do home visits for patients who are not homebound with the goal to help reduce readmissions. So we took that report that we received and we looked at which populations would be best to focus on. And I think specifically what we really looked at was by diagnosis. So we were able to see that we had higher readmission rates for our CHF and diabetes population, and really helped us to narrow down our focus to help determine which populations we should offer home visits to, as we don't have capacity to offer home visits to all of our next-gen patients. We also looked at the demographic data. That's been helpful to share with other committees across our organization. So, the demographic data has things like age on it, so, what age group are having the most readmissions. One of the things that we found on that demographics page was that we had a really high readmission rate for patients who had 2 or more readmissions within 6 months. So we are focusing some efforts on those patients and know that that's a population where we have some opportunities. We're also sharing the data that we receive with our post-acute care internal network. So for those departments such as home care or community senior care that go out to our SNFs, it's nice that the data is broken out into readmission rates for patients from the SNF and then patients who are that DC to a home health agency. And we're sharing that data just for general awareness and also to help give them focus as to what populations they might want to really focus their attention on as well.
Great. Thank you so much, Kristen. So it sounds like you're using the analysis and data from these reports in a number of different ways. And there really is no right or wrong way to use the information in the reports. We just want to make sure here at the LSQIN that the information in these readmission reports is of value to you and the rest of your teams at your hospitals, because that's we're really all about supporting you in any way we can. So we found that through Linda and Kristen's experience with these reports, there's a lot of similarity in how they're using them. They're using these reports to identify patients by demographic population or by diagnoses to see if there's any gaps within their services of care. If they have higher readmission rates, that's maybe an area that they might want to focus their efforts on. And we also see that Kristen is also using her information and her reports to work on some of the service gaps for the post-acute processes. So that kind of ties in with the coordination of care piece that we're trying to kind of make as a theme within these reports. So those are just two examples of how the hospitals are kind of using these readmission reports. So with that, we would like to ask, we'd like to open up the lines to anyone on the call today to share any comments or questions that they have related to this readmission report. So Algie, we can begin opening up for a question and answer session.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. If you have a question at this time, please press the number 1 key on your telephone keypad.
And we also would like to use this as an opportunity to gain any feedback that you have for us, as we want to know if the information in the report that is provided is of value to you and your team. And finally, is there something that you feel that is missing within the report? I mean, that's another piece of information that we would like to hear. When we created this report, we tried to create it as, to be as comprehensive as possible without being too long-winded. But we understand that there may be information that you find important that is missing from the current version of the report. And really, this is an opportunity to share any comments that you may have or any questions.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key on your telephone keypad. We do have one question.
Great.
Please go ahead.
Hi, this is Kristen from Park Nicollet. Can you hear me?
Yes, hi.
Okay, I was just wondering if it would be something that could be included in the report in the future is the percent of patients that readmit back to our hospital, and just to get a better sense of how many of our patients are coming back to our hospital versus how many are readmitting at another location.
I think in the current report, we have something that is similar to that. I have Rahul Paul, our data analyst, who's one of the main creators of the report, is on the call today,
This is Rahul. We can certainly look into adding a column where it looks at how many patients were readmitted back to your hospital. Right now, I think the readmission reports gives you readmissions to any hospital. We can look into how many readmissions are going back to your own hospital. The only limitation that I see here, by CMS rules, we're restricted to suppress any cells that have a number of less than 11. And in that particular case, we might not be able to share that information with you. And as I was looking at it, Ross pointed out that in the report we do have that particular column. If you go to Table 1 in the report, I'm not sure if you have that report on you, but Table 1 in the report has the discharges, the readmissions within 30 days, the rate of readmissions, and then it has how many readmissions went to the same hospital or the hospital reports for, and then the rate for that. So you should have that information.
Okay.
Yeah, so what I'm presenting on the screen, I hope you guys can see it. This is on the current version of the report, and this Table 1. It's one of the first tables within the report, and it just gives you the quarterly breakdown of discharges and all 30-day readmissions with the rate, and then we have readmissions to the same hospital, which are all Medicare fee-for-service beneficiaries readmitted back to your hospital, and then that readmission rate. But thank you so much for your question, Kristen.
So this is Sarah from Lake Superior, Quinn. Raul, could you just speak a little bit more? There was a question in the chat, and you just kind of mentioned it in your response there, but in Kristen's case, she works at a larger facility, and that data suppression might not be as huge of an issue on her report. Can you speak a little bit to what some of the smaller facilities with smaller numbers are seeing, and any suggestions you have for how they might make the data actionable, even if they do have a lot of suppressed data?
The reason we have to suppress data is because CMS requires us to do that, and the reason they do that is to protect the privacy of the patient, so that there's no way to pinpoint a particular patient in the report. What we try to do to reduce the amount of suppressed cells, we try to, especially for the hospitals that have low numbers, we try to roll up or aggregate at higher levels. So in this particular example that we're seeing on the screen, we report the discharges and the readmission by quarter, but for critical access hospitals that usually have lower numbers of discharges and readmissions, we've rolled it up to 4 quarters, so it's rolling 4 quarters. And that helps us reduce the amount of suppressed cells. One thing that I could mention is that if you do see a suppressed cell, you can be sure that it's less than 11. That should give you an idea that it's probably a small number there.
We've thought a lot about this. As far as we want to share as much information with you as possible, but we are. There are certain things we have to protect, especially when we're sharing readmissions to other hospitals. These are all cards, 30-day readmissions, so they include readmissions to other hospitals. So since it's not technically all of your hospital's data, we have to follow the stricter guidelines that CMS has created. So we roll up numbers, we aggregate time periods to share as much information that we can within the report, without losing some of the value. We try to use our deadlines on that. That is a great question. It's something that we're continuously trying to mitigate, and always look for ways to, like I said, share as much information as we can while following CMS guidelines.
Thanks for the question.
This is Laura in Minnesota at LSQAN, and just one other thought you could consider as a critical access hospital if you're looking to use this for improvement is using the state-specific tables in here as ideas for benchmarking your internal data against where you're at. I know some of those things may be less easy to get at, but that might be something to consider if you're one of those hospitals that has suppression issues.
Yeah, and really some of the smaller critical access hospitals are just based on the low volume of discharges that they have with Medicare fee-for-service patients. It's going to be tricky, but we understand that, and we're doing everything we can.
We do have a question from Karen Balmerzak. Please go ahead.
Ashley, that was my question. If those numbers could be, if the suppression number could be raised, that's our hospital exactly. And then I had also typed in another comment in there that Table 6 reflects the state rates, but up above in the description it references your specific hospital. And so I was wondering why we had total discharges of 5,000 when we really didn't. And so I think those descriptions are just copied over from Table 5, if you want to take a look at that.
This is Rahul. Thank you for pointing that out. We do see that, and we will fix that in the next iterations report. Thank you so much.
No, thank you.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. If you have a question at this time, please press the number 1 key. We're waiting for callers to join the queue.
I did want to also mention that we are open to feedback and making changes to the report. It's more or less of a living document of sorts. And with that, we are looking to add some analysis that analyzes the number of adverse drug events, or ADEs. We're going to be adding a couple pages to the report based on ADEs that occur at your hospital. These are devoted to analyzing your hospital's high-risk medication population and instances of adverse drug events. And currently, we're going to introduce this to the Wisconsin PPS and Critical Access Hospital Readmission Reports first, with the potential of these being introduced to the Michigan and Minnesota reports at a future date. But yes, like I said, we have some AE content which analyzes the 3 high-risk medication drugs that we're interested in, which include anticoagulants, diabetic agents, and opioids.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key. Waiting for callers to join the queue. Ladies and gentlemen, if you have a question at this time, please press the number 1 key. No questions at this time.
All right, thank you. If you didn't feel comfortable calling in or commenting or asking a question on the call today, always feel free to reach out to us offline. We understand that a lot of questions can be complicated and complex, and we want to be as approachable as possible. So don't hesitate to reach out to us. Either an email or a phone call.
And just to add on to what Ross said, in addition to that and what he had kind of stated earlier as well, we don't only want to hear what your questions are, we also want to hear how you're using this information.
That's really helpful for us to get a sense of what is the most useful of the information provided in the reports, and it gives us an opportunity to share those examples with your peers across the region as they're looking at these reports and trying to figure out how to make them actionable. So if you have any examples of how you're using the reports now or later, we would love to hear them.
Yes, absolutely, Sarah. I mean, we can talk all we want about these reports, but since we're not working in a clinical setting like the hospital folks are, we don't know how they're being used. And we really appreciate your insight as we feel that others can learn from your experiences at your hospital, and they can implement those into their setting as well.
This is Holly from Lake Superior Quinn. I certainly would like to ask our participants, especially Minnesota and Michigan, what their feelings are with including that ADE information in the report. I don't know if they would find that valuable information or if it really doesn't necessarily impact, what they're trying to achieve within their facility. But if we could get anybody from either of those two states or including Wisconsin as well to see, how, your feelings are in regards to including that as part of the report. We'd really appreciate that.
Yeah, that's a fair assessment, and I really think a lot of times we're adding content to the report thinking that it will be of value to hospitals, and the ADE is one example. So if the folks from Minnesota or Michigan would like to see some information on adverse drug events based around those three high-risk medications, anticoagulants, diabetic agents, and opioids, reach out to your contacts at your respective state and let them know. Or if you don't find any value, let them know that as well. I think that feedback will be important for us to determine whether or not we want to open this up to the reports in the other states as well. And I also wanted to quickly mention that we will be giving an updated version of this report out that goes through Medicare Part A beneficiaries analysis through Q1 of 2018, and we will be looking to get those reports sent out to all PPS and critical access hospitals in the region hopefully by September, and then after that it will be pretty much on a 3-month schedule. So the next one will be in December, and then the one after that will be in February of 2019. So pretty much we're going to be rolling on a 3-month cycle, getting these new updated reports to you guys at the hospitals. So we want to be respectful of everyone's time, and like I said, thank you to those who shared, and if you didn't feel like you need to share, that's okay too. We understand. And always feel free to reach out to us offline if you have any questions or comments or any kind of feedback. We're always open to talking about the reports and making the changes that you guys want so that they have the most value to you and your teams. Very quickly, we do have, there is an update that came in regards to the hospital readmission reduction program, and this is from the CMS quality reporting notification that was sent out on August 2nd of 2018, so just about a week ago. Hospitals have been notified that a confidential hospital-specific report, or HSR for short, will be provided for hospitals to review 2 dual-eligible disparity methods that assess hospital performance for for patients with social risk factors in the hospital's 30-day all-cause risk standardized readmission rates following a pneumonia hospitalization. So be on the lookout for these hospital-specific reports. They are going to be available for you to preview from August 24th through September 24th of 2018. And if you are interested, CMS is hosting a national provider call on Wednesday, September 12th, 2018 from 4 to 5 p.m. Eastern Standard Time to review the disparity method and answer any questions.
So, Ross, this is Sarah. Just to tag on to that in case there's folks who are questioning what that report is, the Hospital Readmissions Reduction Program only applies to prospective payment system hospitals. So for those special access hospitals on the line, you wouldn't be expecting to see that come through. And then the other thing to note is that the most recent information that we have from CMS is to anticipate getting the full Hospital Readmission Reduction Program preview report sometime in August. You know, last year we received that data either in May or June, so it's a bit later this year than it has been in years past, but they did on a recent webinar say that we should anticipate receiving it. They actually said early August. It's August 8th, and we haven't seen it or heard anything more yet, so I'm going to go ahead and say mid-August, hopefully, is when we'll see that.
Yes, thank you, Sarah. And we also did receive a question in the chat. Is there a simple procedure on how to read the report and use it, and how the information is collected for it? And she's referencing ICD codes.
This is Rahul. Ross mentioned and put a YouTube link on the slides. I think it was the first or the second slide. That would be a good place to go and understand how the reports are created and how to potentially use them. We are planning to put the ICD codes used on a web page, and we will be putting once the web page is up, we will put the link to the web page in the report, and whenever you get the next iteration of the code, once the pages are up, you should have the link to it, and you should be able to go and view the ICD codes used for each diagnosis that's listed in the demographic stage.
Yeah, thank you, Rahul. And really, this webinar is, I'm on the slide I'm on right now, it's at that link at the bottom, that YouTube link. That webinar is the introduction webinar where we really go over each page in the report, and we provide as much detail about the page contents and the source of the data, and how we suggest that it be used to identify gaps in care or quality improvement projects or focuses. So we really kind of provide that intro to the Quarterly Hospital Readmission Report on that in that recording that is linked at the bottom.
Hi, Ross. This is Janelle. I'm just wondering, are we also including that link in the email communication when we send the reports, or could we do that so people don't have to try to write that long URL down and find it?
Yeah, I know, that's unfortunate. With the email outreach, we send out emails to the hospital contact that receives the reports through QualityNet. We do provide links to that introductory email. And some folks on the call today may be not as familiar with the reports because they are not the central contact person that receives the reports. So we can, I would advise that you reach out to your state LSQIN contact to find out who your hospital team member that received the report is. And that probably is the link to the,
we can potentially put it in, so this is Rahul again, we can look into putting the YouTube link in the actual report as well. Hopefully that will make it easier for people to navigate to that YouTube link on there. Thank you for that suggestion.
Yeah, we'll get your questions from me. So these are the contacts for each of the each of the states within the Lake Superior Quinn. So if you do have any questions about the reports or feedback, whether it's about the report itself or who at your hospital is receiving the report, and would like to reach out to one of us here at the Lake Superior Quinn, here are each of the 3 state contacts. And I also want to remind, I'm sorry, did someone?
Oh, go ahead.
Okay. And I also want to once again remind everyone that we would very much appreciate you filling out the evaluation at the end of this call as we use that information that we gain from that evaluation to make any improvements to the readmission reports in the future. And with this, we'll take one last opportunity to ask if anyone has anything they would like to add or any questions or comments.
You were cool.
Ladies and gentlemen, if there's a question at this time, please press the number 1 key. If there's a question at this time, please press the number 1 key.
Well, this is Holly from Lake Superior. One of the questions that I got emailed during the week, and I think this was also addressed in the FAQ document that was created, but one of the things was it was pretty much whether hospice patients were included or excluded in the data. And so I don't know if you could talk to that a little bit more, but, essentially hospice patients are included in the analysis. And, we realize there can be some, concerns in regards to, adding that patient information in, but they removed the hospice information as a category because of the number of discharges and readmissions from the hospice setting were so small. I don't know if you could add anything, to that to talk about that, but, that question did come up, during the week.
Yeah, thank you, Holly. We originally had as far as part of the post-acute section of the report, one of the last pages on the report, and we originally were listing the number of patients discharged to a hospice setting and having their readmission rates as well, but just due to the extremely small numbers, even with some of the larger PPS hospitals, some of those that had 2,000 discharges in a year, we were having to suppress many of those readmissions. So we didn't. And the whole remember anything on that?
So when we do the initial analysis and we are calculating the readmissions, we do include all of the hospice patients or patients that were discharged to a hospice from the hospital where the next admission was. But we, in the table 5, where we split up those readmissions into a particular discharge setting, we have home SNFs and home health agencies. We had an additional couple of columns where we looked at the number of discharges to and readmissions from hospices. But since even for, like Ross mentioned, even for some of the larger hospitals, those numbers were so low, we had to pretty much suppress every cell in there. So we ended up cutting those 2 columns because there was very little information that could be gleaned from there. But they are included in the totals that we see when we are looking at admissions and discharges and readmissions by quarter or by rolling 4 quarters, whether if you're a PPS or a critical access hospital. Does that answer that question?
Oh, absolutely. Yes, thank you for adding that information in. I didn't know if any other facilities are, experiencing, any, situations that, might affect those numbers. So thank you for that.
Thank you. We just received another question from Cindy. Our hospital is listing planned 3-bed admissions from our acute LOC as readmissions. Does that statistic transmit to you? That's a great question. After we had the introductory webinar to the hospital readmission report, this is one of the questions that we received from multiple hospitals. Do we consider a transfer to a swing bed, into a swing bed facility for certain things such as rehabilitation? Does that count as a readmission? And our answer that we use within this analysis, that would not count as a readmission. The code that we use to analyze claims identifies a swing bed stay as a stay that is similar to one at a skilled nursing facility, and therefore it's not considered an inpatient stay. So that would not count as a readmission to another inpatient setting. And we kind of determined that we would use that methodology based on what CMS determined as a readmission. It's an all-cause inpatient admission back to any hospital, whether that be a PPS, a critical access, or an inpatient psychiatric facility within 30 days of discharge from another inpatient setting. That's a good question because there are some variations in how people define a readmission.
And that's a good point, Ross, too, because I often get questions, this is Holly again from Lake Superior, I often get questions, what happens, with snowbirds? So, they're in the, hospital here in Michigan, and, they get discharged, and then they go out of state to another facility, different CCN, who is really essentially taking the hit for that readmission. And, essentially it's that primary hospital that admitted that patient at that time. So it's, we'd like to think that, it would stay within state borders, but it crosses state borders in this particular case as well.
No, you're absolutely right. And that's one of the things to think about, that it's all about the initial admission, and then once the patient is discharged, then it starts that 30-day clock.
And it can be a completely different diagnosis as well, so it doesn't have to be that same, initial admitting, event. It can be completely different. So, definitely worth exploring, especially if they're, related admissions.
Yeah, so a patient could be admitted for pneumonia, discharged with that primary diagnosis of pneumonia, and then come back to the hospital for a fall, and that would still count as a readmission for that initial admission of pneumonia. And that's one of the ways we use that as a way, because that's how CMS defines their readmission methodology, and they use those for the counseling programs such as the hospital readmission reduction program. Yeah, I mean, there's a lot of nuances as far as the data analysis goes. So we do our best to define data sources and how we calculate things, and there are data descriptions on each of the pages that we hopefully do that justice. So let us know if you still need explanations on certain things. So we got two new questions, one from Rita. Just to clarify that an inpatient returns in 15 days to the hospital as an observation patient. This would not count as a readmission, correct? That is correct. Once again, for our purposes, we do not classify an observation stay as an inpatient stay, so it would not count as a readmission. Observation stays are classified as such as skilled nursing, discharges to skilled nursing facilities, or even a swing bed facility, I guess, as well.
And observation stays are classified as outpatient rather than inpatient, so they do not count as readmissions, but we do have tables 8 and 9 where we do list out inpatient admissions within 30 days of discharge, ED visits, and observation stays. That would normally be included in there, but we do not include them again because of low numbers. ED visits and observation stays count as outpatient While when we are looking at readmissions, we're looking at inpatient readmissions. Hopefully that answers your question, Rita.
Thank you, Rita. And we also have another one from Sharon. If a patient is admitted to hospital A, discharged home, admitted to hospital B, discharged home, and admitted to hospital C, all within 1 month, where does the readmission go? So who gets billed for the readmission? If it's all within 1 month, it better go to hospital A, because they're the initial inpatient, index, thank you so much.
Admission.
Yeah, so once the patient is admitted to a hospital, that starts the clock for that particular hospital.
Right, and any readmissions attributed to that index stay.
So that's another good question. I mean, like I mentioned before, there's a lot of nuance and there's a lot of different situations that can lead to different results as far as the admission rates.
This is Holly again from Lake Superior. As Ross had suggested at the beginning of this event, certainly any feedback that you have regarding this particular learning event, or if there's anything that you would like to see as a future learning event educational session, whether it's in this format or if it's in a webinar, certainly provide that feedback to us in that questionnaire that's going to be popping up shortly. But, any feedback that you provide, whether it's the hospital reports or if it's the, upcoming learning sessions, we take your feedback very seriously because, we essentially want to be able to offer you both the tools and the resources needed so you could be successful at your facility.
Yes, thank you, Holly. So we have about 10 minutes left. So we would still be available for any questions or comments that you guys have, but we don't want to keep you guys on too long if there's not too much discourse going on. So I guess we'll wait maybe like another minute or so for any questions or comments, and we can wrap up the call if we don't hear again.
Okay.
Ladies and gentlemen, if you have a question at this time, please press the number 1 key.
All right, so again, if there are no other questions, this concludes today's office hours call. This recording will be available in approximately 2 weeks on the Lake Superior Quinn YouTube page at www.youtube.com/user/LSQIN. Once again, please take a moment to complete the evaluation, as the feedback that you provide helps us continue to make these quality events as valuable to you as possible. Thanks for your time and have a great day.
Ladies and gentlemen, let's